The next speaker who is going to be Dr. Stephen Wank, who is the director and chief of the digestive disease section of NIH, National Institute of Health. And he's been very interested for a number of years in hereditary types of carcinoid. And there is an apparent entity called familial carcinoid, different from the MEN syndrome. And he's been working in that field, and he will tell us more about that.
Good afternoon. Can you all hear me just fine? No? Maybe the microphone needs to be a little bit higher up. Now? Must be the guys back there. Yeah, no problem. How about now? Better? Okay. Great. So thank you, Dr. Warner, for the introduction, and I want to thank Marianne and Bob Wadman for inviting me to come here. And this is my first large patient meeting that I presented at. And my first reaction when I saw this crowd was just one word, and that's wow. The number of people and the questions that you've asked and the sophistication that you have is admirable. The second thing I want to say is I'm going to present some work, and the work that I'm going to present could not have been done without patient advocacy groups like yourself. When I started out, I thought I would get my patients from clinicaltrials.gov, patient referrals from other physicians, but in fact, 90+% came from grassroots groups like yours. And I can't say how important the kind of work that you all do is, not just for yourself, but for others, and it enables the kind of research I'm going to talk about today. I work for the government, so that's why I have this slide and nobody else does. Probably there's someone in the room watching me. But. Okay, I'm going to make a few things clear that I know this sophisticated audience already knows and has been gone over today. But you've heard a lot of information yesterday and today, and I want to just be absolutely clear about what I'm going to say. Unlike the title that is in your program, first, I'm going to speak only on what people call midgut or small intestinal carcinoid tumors. And that's shown here in the slide. Whoops, wrong button. I knew I'd do that. Okay, let me get the laser pointer. So I'm going to be speaking about the small intestinal neuroendocrine tumors, and this is an embryonic classification that you heard about earlier. I'm not going to talk about MEN, and I'm not going to talk about other pancreatic neuroendocrine tumors. I'm going to speak just on small intestinal carcinoids. And furthermore, I'm going to try to convince you, and we'll see how well I do, that there are two types of small intestinal neuroendocrine tumors. There's a sporadic type, and there's a familial type. Now, you're all probably scratching your head and saying, I've never heard of the familial type. I thought there was just small intestinal neuroendocrine tumors. And I'm going to try and give you the data to tell you that the small intestinal neuroendocrine tumors are not a small minority. They may not be 50%, but they're somewhere between 30+% of these tumors. So let's get started and see what I can show you. Again, I'm going to review a little bit to get everything squared away about gastroenteropancreatic neuroendocrine tumors. Again, I'm talking about carcinoids in this sense, using the word of tumors that come from either ECL cells or EC cells. Those are enterochromaffin-like cells or enterochromaffin cells. And in fact, I'm going to talk just on those that come from enterochromaffin cells that exist in the GI tract. Below the yellow, you see the other type of tumors that are pancreatic neuroendocrine tumors that you heard about earlier. I'm not going to be talking about them. You may have seen this slide in past meetings. This slide pretty well sums up and gives a background for the impetus of our work. And what you can see on this lower bar is that, and this whole graph is sort of a time course of small intestinal neuroendocrine tumors. And you can see that the primary tumor goes for many years before it becomes known. And that's the deadliness of this disease. Small primary, you've been hearing about the inverted triangle. Small primary that may or may not be symptomatic, going along for years, all of which time it starts to metastasize. And it's not, for many patients, unfortunately, until it becomes fairly large in the liver, overwhelms the liver, and gives the carcinoid syndrome. If you're lucky, you might get a bleed in the primary and get it picked up earlier. You might have an obstruction that might get you there earlier, or you might go in for some other reason and get it diagnosed incidentally. So I'm just going to summarize the background of what's known before we started our work. That non-familial small intestinal neuroendocrine tumors are generally solitary tumors predominantly, but the literature shows that there have been multiple synchronous tumors, and depending on what study you read, somewhere between 22 and 39%. There have been case reports and epidemiological evidence that familial occurrence of these tumors. Now keep in mind that these tumors are relatively rare, in the range of 1 in 100,000 incidents. Yet how would you explain having more than one in a family at such a rare occurrence? As you know, they're slow growing, they have a late onset, they're often misdiagnosed and therefore a late presentation. They often, unfortunately, result in a carcinoid syndrome, and the extent of disease is often related to the primary size, histology, and duration. Survival, as you've heard, is reduced with distal disease, and unfortunately, the tumors are minimally responsive to chemo and biological and radiotherapy. And as you've heard earlier many times, they're best managed surgically, especially if you can catch the tumor early. So the last few slides of background. And let me say what got us started. We regard and respect a lot of the terrific work that's been done in this disease, but understanding the molecular basis of carcinoid tumors has been relatively slow going. So we thought, well, maybe there's another approach that's been successful in other tumors that are familial tumors. You all know about familial breast cancer, familial colon cancer, and even some familial neuroendocrine tumors like MEN. So we thought, well, maybe there's a familial midgut carcinoid tumor. And so we went into the literature, and I told you already that 22 to 39% of what so-called sporadic tumors have multiple synchronous tumors. In the 50 years before we started, there were only 5 case reports of 7 families. And I've listed those families there. 2 with a brother-sister, 2 with a father-daughter, 1 with 2 sisters, 1 a sister-brother and a niece, and 1 with 3 men involved over 3 generations. In addition, there was a nice study a while back from the Mayo Clinic showing 10 carcinoids in relatives, and basically what it showed is that the relative risk went up almost 7-fold if you were a relative of someone who had the disease. And finally, there was a Swedish registry study showing that the standard incidence ratio goes up 12 times in parent-offspring pairs. So with this background and information in hand, we made the following hypotheses, which are just a scientific word for assumptions that need to be proven. And it goes like this. we hypothesized that multiple synchronous carcinoid tumors represent germline disease. That is, you have a DNA defect that's in all the cells of your body. And that these defects make you more susceptible to a tumor. And since all the cells have it, there's no reason why it should be in just one place at one time. It could occur in many places. We hypothesized that the familial occurrence of these is heritable. That is, it's in the DNA. It's not due to infection, and it's not due to the drinking water or environmental factors. And we felt, as I mentioned earlier, that if we were to evaluate familial disease and we were successful, like others have been and others, that perhaps we would have a similar kind of application to sporadic disease. And so we also assume that if all this background is true, and we intensely evaluate asymptomatic, that is, just people who belong to a family, relatives of someone who has the disease, but they have two members in the family, then if that timeline I showed you was correct, they may be harboring a small tumor that they're not aware of because they have no symptoms. And as you've heard today and I've mentioned earlier, if we can make this diagnosis early and treat these occult tumors, we ought to be able to improve the natural history of the disease. So, to test these out, we wrote a protocol in 2008, and remember that we have no history of studying small intestinal carcinoid tumors, so it takes a ramp-up time, and it takes people like you to allow us to get patients and be successful. And so what we set out to do is to look at the natural history of familial versus sporadic disease. We wanted to know what are the best diagnostic modalities because, again, we're going to be looking at early disease. We can't use gross tests when the patient's already sick that are successful. We got to find it when it's small. And then we want to know if we act on this, can we alter the course of the disease with the early diagnosis? And finally, we'd like to know, are there any susceptibility genes that are responsible for these familial cases? So this is a protocol. It's a prospective open-ended natural history study of families with small intestinal neuroendocrine tumors. Patient recruitment was, as I said, from support groups like you all, clinicaltrials.gov, and physician referral. Remember, at the NIH, we don't get walk-ins. Anybody who is at the NIH has to be on a study. And these are rare diseases. We really need to cull patients like yourselves from all over the country, if not the world, because they're rare. All right, to get into our study, you have to either be an adult with carcinoid tumor yourself, and then have another relative with diagnosed and documented carcinoid tumor. Or you can be a normal person, but you have to have two people in your family that have the disease. And we exclude everybody with a known familial disease because that's not what we're studying. So here's our very simple study design. If you belong to that purple group that I just described, you sign a consent after being informed of the protocol, and this is what happens to you. You come into the clinical center, you get imaged. And I have to thank Dr. Mauricio and Dr. Bushnell for doing an excellent job going over the imaging because it's central to our protocol. We do CT enterography, 18 fluorodopa PET scan that you heard at the end, MRI if there's liver disease. We look at neuroendocrine biomarkers, the ones you're familiar with, the urine 5-HIA, serotonin, chromogranin, histamine, pancreatic polypeptide. And we do endoscopy. And I thank Dr. Metz for his lovely speech. We do video capsule endoscopy, upper and lower endoscopy. And then if we find that there's something there, then we send you to the surgeon for exploratory laparotomy. If we don't find anything, then we come and reevaluate you every 2 or 3 years. All right. I know you're a sophisticated group, and I'm going to show you some graphs that I think you'll be able to understand. This is our experience looking at family members with traditional tests. In this case, it's chromogranin A. And what you see on your left is a comparison of what the results are in chromogranin A in patients that we found had tumor from those that did not. And what you should take away from this is that we could not tell who had tumor and who did not in a family. So that if you look on the right, after we compare those who had tumor, that's the lower red bar, and we compare them to relatives who had symptoms, all right, unlike the asymptomatic ones. Well, the ones with symptoms have more disease, and their test is abnormal. So this is a good test. It's just not a good test if you have early disease. So patients always ask, I don't need to come to the NIH. I saw my doctor, and he got a 5-HIA, and it's normal. I can't have anything. But that's not our experience. And the same is true, and here's the data, about serotonin. Just because you have a normal serotonin, if you belong to one of these families, you still are at risk for the disease. And even urinary 24-hour 5-HIA, same thing. We had only one patient, and I'm going to tell you about our patients. Only one patient had an abnormal urine 5-HIA of the asymptomatic patients. Now, all their relatives who had advanced disease, yes, these tests were abnormal. So, what can we conclude? Traditional biomarkers used to diagnose sporadic midgut carcinoid are also useful for symptomatic familial disease. However, they have no diagnostic utility in screening high-risk asymptomatic family members with early, potentially surgically curable disease. More sensitive biomarkers are needed for early detection in high-risk patients with familial, as well as patients with sporadic disease who have early disease. Now, another test, so those are the biomarkers. Another test we do that Dr. Metz introduced was this video capsule endoscopy. And so here's a picture of what it is you swallow. And it's basically like the Fantastic Voyage film that some of you are my age may remember. You swallow this capsule, it's got a camera, and it takes 55,000 photos as it courses through your small bowel over a period of 3 to 5 hours. And then, as Dr. Metz alluded, you look at a video to see. You put on a belt, or you can put on the individual leads, and then that just shows you the size of the capsule next to the fingers. Here are some images, all with yellow arrows to guide your eyes as to how subtle these submucosal tumors are. The overlying mucosa is generally normal, and these little bumps are often very hard to diagnose, and it takes someone with a lot of experience to pick it up on capsule endoscopy. Here are some other images, again, showing very subtly. Some of these tumors are subtle, some are quite obvious. Again, you can see the variety, and I can tell you that some of the folds and normal contractions of the bowel can really fool you. And you got to be sure, because you don't want to send an asymptomatic patient to surgery because you overinterpret a positive capsule study. Now, I don't have to spend too much time because my predecessors did an excellent job, but here's the Tria scan, which we did initially for several years in our study. And you can see with the arrow where the lesion is. Now I'm going to show you an old generation PET scanner without the CT. Well, first let me tell you about 18-fluorodopa. I don't have to tell you too much because Dr. Bushnell did a good job on introducing the fluorodopa scan. That's principally what we used until this past year, where we added gallium. I'm going to show you a little bit about gallium scan. But basically, the other thing that Dr. Bushnell did not mention, although I'm sure he knows, is that to get this tracer, you need an on-site cyclotron, which is why so few people have this. Fortunately, at the NIH we do, and we didn't have gallium at the time. And so we took advantage of this scan, and I'm going to show you a little bit about that. So here's that same Tria scan, only this is an 18-fluorodopa PET scan without the CT and an old generation scanner. And I'm going to show you that that lesion that looked like a single lesion on the Tria scan really is a series of several lesions, which is what you would expect in a familial carcinoid if you believe that the multiple synchronous lesions are due to germline mutations occurring multiply. Now here's a comparison. You've heard about gallium compared to Tria scan, and I completely agree with everything that was said. What you haven't heard, and there's only 1 or 2 papers in the world literature comparing 18-fluorodopa to gallium, and that was alluded to earlier by Dr. Bushnell. And so what you can see on the panel on your left, under 18-fluorodopa, you can see multiple liver lesions that are absent on the gallium-68 dotatate. And then right below it, you can see that some lesions are picked up well on both scans. And I will just, the point of my talk is not a radiological one or a nuclear medicine one. I will just say that the gallium is an excellent scan, and everything that you've heard before has been our experience as well. However, we do find that the 18-fluorodopa is more sensitive and has some advantages. And one of those is, if you look on your right, you'll see a splenic tumor on the 18-fluorodopa. And you cannot see it on the gallium because the gallium has a very high background in the spleen. That's another area. And then with regard to MRI, we don't find MRI to be very sensitive, although when it is positive, it's the best test of the liver for actually looking at size. And here's an example where MRI is negative, 18-fluorodopa is positive in the liver. So what we conclude is that the gallium-68 dotatate, not the dotatalk you heard about, but very similar, is superior to conventional imaging, but slightly inferior to 18-fluorodopa PET-CT. We find that there's increased pancreatic uptake, probably normal physiologic, but it becomes an issue when you're looking for pancreatic lesions. We failed to identify a foci. I showed you comparing the two, but the gallium, as I said, is very sensitive and also much more cost-effective. And the reason we're doing it at the NIH is, for the same reasons you heard today, trying to get this out so that community hospitals can have this kind of study, which is badly needed. All right, I'm going to go quickly through the CT scan because you've already heard a lot about it. And we use this to diagnose our patients as well. And you can see from the arrows these hypervascular lesions. And what I want to show you in this, besides all these scans, is that there are multiple tumors. This is the same patient. This is tumor 2A. This is tumor number 3, tumor number 4, tumor number 5, 6, and those are all primary tumors. Lastly, MRI is, I agree with Dr. Bushnell, not very good for small bowel. It moves around too much. This is one lucky case where we were able to find it on MRI, but very unusual. So to sum up our interim analysis of these imaging studies, the 30 patients that I'm going to tell you about, and you can see on your left how often these tests, PET-CT, video capsule, or CT, were positive. And fortunately, when one or the other is negative, the other one picks up what the other one misses. And what you can see is that video capsule endoscopy is very, very sensitive. It equaled, in our study, PET-CT. And that CT was very good, but not as good as the others. And that's summarized in this slide. And I'll just say, in addition, that EGD and colonoscopy had no value. Our Tria scan only picked up one patient that was picked up elsewhere, and biomarkers had little to no value. All right, I told you that we thought this is possibly a genetic disease, so let me give you some evidence. I'm going to show you one of our families, and I don't know how used to looking at pedigrees you all are, so I'll bring you through it a little bit. As you go down from the top to the bottom, those are generations. And what you can see in the second generation with the Roman numeral 2 is that there are several patients where their circles are squares are filled in with black. Those patients have small intestinal neuroendocrine tumor, and if the line goes through them, they passed away. And so This family presented to us with this situation. And we were able to get DNA from 5 out of the 7 people who had the disease. But that isn't enough to do linkage analysis and figure out the gene, because this is a late onset, incompletely penetrant disease, and you can't rule anyone out, even until at least you have an autopsy. And it may even skip a generation. So, by screening for patients, we were able to do the following. Now you see some red circles and squares. We evaluated 47 patients from this family, and we were able to pick up 6 new cases, all asymptomatic, and take them to surgery and prove we were correct. Now this gave us enough patients in this family to do linkage analysis, where we would have had to wait till they got sick, maybe 10 plus years. One of these patients' bowel is in front of you, and what it shows are some of the multiple tumors that these patients have. I'm going to give you a complete case from this family. You can see the CT scan with those 3 white arrows that are positive. You can see the same lesions on the PET CT, this time a late generation PET CT scanner from 18 fluorodopa. You can see the positive capsule. You can see the bowel that was removed, and every suture thread you see there represents a different tumor. This patient had maybe 17 tumors. You can see it's submucosal. When you open it up, you see the white material that's revealed, and you see it's typical on H&E of the islets that you expect. You see the Ki-67 is low, it's consistent with a grade 1 tumor, and then you see the positive staining for serotonin, chromogranin, and synaptophysin. In regard to enrollment and sample acquisition, I have a few statistics because we're relatively new at this compared to everyone else who's speaking today. So far, we've been very fortunate. We've enrolled 294 patients. We've evaluated at the clinical center 248. We admit about 100 patients per year. We've collected almost 2,000 blood samples and plasma and serum samples. We have 88 living affected patients, 28 occult tumors. And we have evaluated 50 families, and we have 13 families waiting to be evaluated. We have 293 fresh frozen tumor samples, 350 FFP samples. We operated on 35 patients. 22 had occult tumor. We reoperated on patients that come to us, quote unquote, cured, because their CT and MRI are negative, but are only found to have tumor on F-DOPA scan. And some decide to have surgery on the outside. So let me go through with some detail our interim analysis. I say interim because this study is going to be ongoing indefinitely. And these are 33 families so far that we've evaluated completely. So from these 33 families, unfortunately, 35 passed away, but we were able to get medical records on 33 of them. The remaining 181 patients from these families were evaluated on a 3 or 4 day stay at the NIH. 44 of them had previously diagnosed disease. 137 were asymptomatic. We screened 137 asymptomatic patients and found 29 of them screened positive the way I described to you earlier. Of those 29, 1 was lost to follow-up, 2 are considering surgery, but 26 had surgery. Out of the 26 that had surgery, 23 of them were true positive. So if you come to us and you belong to one of these families, you have a 1 in 6 chance of being found to have tumor, even though you feel fine. If you're over 50 years old and you belong to one of these families, you have a 1 in 3 chance of having tumor. So what kind of families do we have? Yeah, I know I'm running late, but I'll also remind you that I was 10 minutes late in starting. With regard to the distribution of affected families, this is a very complex graph. I'll try to take you through it to make the point rather than showing you 33 pedigrees. Most of our families, as you can see across the bottom here, are the number of patients in a family that are affected. And going up are the number of families with those numbers. And what you can see is most of our families have 2 and 3 affected family members. We do have some large families. I showed you one with 13. We have one with 7, a couple with 6, and so on. And let me just quickly go through the clinical characteristics because this is the meat of the talk right here. You see 2 columns. One says screen positive and one says symptomatic. So all these patients belong to the families, the 33 families. The symptomatic ones are the ones who came to us with known disease. The screen positives are the ones we found. And now we're going to look at how they differ. They differ in age by about 2.5, 3 years, but that's not statistically significant. In terms of survival, all of our patients that we screened are alive. However, if you present with symptoms, we have data from 38 of the 77, they died within 5.5 years. None of our patients have any evidence of disease except 2. One that had liver disease when we operated on them, and one who had a lymph node that was deep mesenteric and couldn't be removed. Compare that, admittedly, only to 9 out of the 77 who have no evidence of disease for a longer period of time. That's 94 months. Now move down to the red circles, and you'll see that, as you would expect, all have early stage disease in the screen patients, whereas only 30% had early disease by the time you're symptomatic. As you can see in yellow, everyone had early grade 1, not early, but grade 1 disease. The number of tumors per patient was approximately the same, between 6 and 7 tumors, primary tumors per patient. In our families, when we screened them, 83% had multiple tumors. And we think probably a higher percent, but we just caught some early. And 67% of the members who presented with symptoms had multiple tumors. To prove that this is a genetic disease, I'm showing you that same family again. We did linkage analysis on them, and we found a linkage peak on a genome-wide scan that has a significant lot score. And all you need to take away to understand this is that we were able to link the disease to a genomic region with a very high probability. And that's what that lot score refers to. We were able to actually narrow it down to a small interval on a chromosome, and that's what the bottom graph shows you. We've identified this disease, and what you can see, if you go back and look at the top, is that there are 35 people in that family that we could not find disease just yet. Some are very young. And as you would expect for an autosomal dominant disease, half of them carry the disease mutation. So to summarize and conclude, and I should just be on just about correctly on time for starting late, familial and non-familial carcinoid are clinically similar except for the presence of multiple synchronous tumors. A familial carcinoid tumor occurs on a heritable basis as opposed to environmental or infectious in a simple Mendelian autosomal dominant mode of transmission. The onset is late, the penetrance is incomplete. There are multiple tumors we believe represent individual clones consistent with germline disease, and it may account for up to 39% of what everyone has been calling simply small intestinal neuroendocrine tumor. Screening with the fluorodopa, the capsule endoscopy and CT are the most sensitive and specific tests. I told you about the problems with Tria scan and the biochemical tests. And we recommend that families should be screened for occult disease, that the high rate of detection in asymptomatic relatives that I told you about warrants it. That we did not, in our study, find any tumor in patients under 40, but we haven't seen that many patients, and we do have families with people under 40 who are affected. But as a cost-effective and as a risk-benefit ratio, we don't look at patients generally less than 40, although we looked at many to come to this conclusion. We believe, and I believe I showed you evidence, that screening detects early-stage disease, that surgery can be curative and changes the natural history of the disease, although I will take criticism that we've only followed some of our patients out for as much as 5 years and not with an average of maybe only 36 months, and they could still recur. So that's a tentative statement. Our current work, and this is the last slide, is we're continuing linkage analysis on other families, whole exome sequencing, tumor analysis. We're looking in the future for gene mutations that can explain the pathogenesis of the disease, and we hope to identify and follow families and offer surgery for the long term. And hopefully we'll learn about better therapy by better understanding the disease. I need to acknowledge these people who helped me. I obviously could not have done all this by myself, and really on top of all these people in big bright red letters should be you all's name for enabling us to even conduct such a study. I thank you so much for listening.